Honorable experts or honorable experts of the day, Dr. Suneela Garg, Dr. Rajesh Kumar ji, Honorable Vice Chancellor, Professor Nagesha Rao ji, who is busy in another pre-decided meeting, Honorable Professor Pro Vice Chancellor, Professor Satyakam sir, who will be the chair of this session, directors of the school, heads of the divisions, regional directors, faculty, and staff. It's my privilege and also the pleasure to welcome you all on this World Health Day. As you all know that World Health Day is celebrated every year with focus on specific contemporary health-related or health-related issues through various themes every year across the globe. And the present year's, that is 2022 theme of World Health Day is Our Planet, Our Health. This theme focuses on the efforts of all the nations globally in order to focus on urgent actions to take care of humans and also to take care of planet in general. The theme also reflects a cause of concern which is growing over whole world of ecological changes on the health of humans and planet as a whole. The climatic crisis, which has resulted in lot of problems in health, are needed to be addressed globally, which is focused by WHO for taking all the actions as said earlier. The climatic crisis poses a great threat to the mankind and the climate. That's why whole world and whole nations are coming together and putting their heads together and doing think tank regarding how climatic change can result, a better climatic change and modification in the climate can result in the health of the health and well-being of the people and also the health and well-being of the nation. Because the climatic crisis, which may be, we should say that triple climatic crisis, which include the climatic change, the biodiversity loss, and the pollution, has created a havoc and has also posed a serious threat to the health of the mankind. And we have there to introspect and also take action, whether we can make the clean air, clean water, and also the clean food available to all our societies. The WHO also focuses on creating the campaigns and creating the societies which focus on health and well-being. Also, the focus is on creating the infrastructure, the economies, which will focus on health infrastructure and also the better quality of life. Although the nations, including India, is taking a lot of efforts for the sustainable development and reaching the goals which are set by the Sustainable Development Goals 3 and 6, mainly related to the health and safe water. And there are many plan of action which has been taken by the government of India. I would just see that there are so many commissions have been formed for addressing the climatic change so that the health of the nation is safeguarded. There is the National Solar Mission, National Mission for Enhanced Energy and Efficiency, National Mission on Sustainable Habitat, National Water Mission, National Mission for Sustaining the Himalayan Ecosystem, National System for Green India, and National Mission for Sustainable Agriculture. These are the initiatives which have been taken by the government of India in order to achieve the targets and goals. We can also say that not only these, lot many schemes and schemes, we call them that yojana, have been formed, created by the government of India, the Prime Minister, under which we can say there is Ujala Yojana that also affects the health problems due to smoke and all that. We can also talk about the SOHS.Key Abhiyan, which also helps the planet. We also can talk about Mudra Yojana. We can also talk about Awas Yojana, and we can also talk of Jan Dhan Yojana. And these are all steps. These can be, and also a big regarding the health is Ayushman Bharat scheme. So these are all the schemes which facilitate the improvement of health and well-being of the nation. So with these few words, I would like to introduce the experts of today before I give my Pro-Vice Chancellor to speak on the occasion. So I will start the introduction of one of the expert, the guest of the day, of the present day, Dr. Suneela Garg, who is Professor of Excellence, Community Medicine, Chair Program Advisory Committee for National Institute of Health and Family Welfare, National President IAPSM 2021, National President OMAG, Collaborator FOPL Advisory Co-Project Lead addressing smokeless tobacco, the ASHA, which is also called as ESTRA. She's an MD from MGIMS Sevagram. She has 40 years of professional experience. She has been formerly sub-dean and head of the community medicine department in Maulana Azad Medical College. She has been in charge of our postgraduate diploma in geriatric medicine till 2021, and also the coordinator for postgraduate diploma in maternal and child health. She has been resource person for various expert committees and other meetings. She has also been the former head of Faculty of Medicine, Delhi University, advisor, Indian Council of Medical Research, and member Task Force Department of Biotechnology, Director Society of Sound Hearing International, Fellow WHO, DFID UK Alumni, London School of Hygiene and Tropical Medicine, Coordinator for Action Document on School Opening as IAPSM President, awarded K.N. Rao Memorial Oration of Indian Public Health Association 2018, awarded Harcharan Oration of IAPSM for the year 2019, awarded State Award for Meritorious Services, published around more than 200 papers, manuals for WHO and Ministry of Health and Family Welfare, resource faculty for leadership and management, coordinator for yoga and positive health in medical fraternity. She has had many media talks and press briefs about more than 250, member Lancet Commission COVID India Task Force and on hearing, expert vision document addressing sustainable development goals 5, 10, and 16 of Ministry of Women and Child Development, Government of India. I welcome you, madam, to this program. I would also like to introduce our other expert guest speaker, Dr. Rajesh. Dr. Rajesh Kumar is a technical advisor, Health Systems Transformation Platform, New Delhi, Honorary Professor, London School of Hygiene and Tropical Medicine, UK, Visiting Professional Fellow, School of Public Health and Community Medicine, University of New South Wales, Sydney, Australia, Associate Editor, Journal of Epidemiology and Community Health, and member of WHO Technical Advisory Group on Mother and Newborn Information Tracking of Outcomes and Results. He is currently member of National TB Operations Research Committee and HIV Technical Resource Group on Surveillance and Estimation. He has worked as Executive Director of State Health System Resource Center in Punjab, Emeritus Scientist of Indian Council of Medical Research, Dean Academic and Head of Department of Community Medicine and School of Public Health at PGI Chandigarh. He obtained MD in Social and Preventive Medicine from Medical College, Rohtak, India, and MSc in Epidemiology from London School of Hygiene and Tropical Medicine, UK. He is a fellow of the National Academy of Medical Sciences, India. His areas of work include health service research, planning and evaluation of health programs capacity, building of health workforce, and public health informatics. He has published more than 450 research papers, which are in high index 63 and to 25,094 citations. I welcome you, sir, to this program. Now I would request our Honorable Pro Vice Chancellor, Professor Satyakam, who is the chairperson of the present program. Sir, I request you, he's a backbone of the university, and most of the decisions and the most of the activities are being undertaken by him as an important member of the team of the competent authority at IGNOU. I would, Professor Satyakam sir.
जी, धन्यवाद प्रोफेसर पीटी कौल जी। सबसे पहले तो मैं आपके प्रति अपनी कृतज्ञता व्यक्त करना चाहता हूं कि आपने इस महत्वपूर्ण अवसर पर मुझे इसमें शामिल किया, और मैं पूरे स्कूल ऑफ हेल्थ साइंसेज को भी बहुत बहुत बधाई देना चाहता हूं कि आपने वर्ल्ड हेल्थ डे के अवसर पर ये कार्यक्रम किया, जो कि आज की जरूरत है, आवश्यकता है। हमारे सामने दो प्रमुख चिकित्सक और डॉक्टर्स, रिनाउंड डॉक्टर्स हैं, जिनकी बात सुनने के लिए आज हम सब लोग इकट्ठे हुए हैं। मैं डॉक्टर सुनीला गर्ग और डॉक्टर राजेश कुमार जी का स्वागत करता हूं इग्नू की तरफ से, और अपने कुलपति की ओर से आज आदेश हुआ मुझे कि मैं आप लोगों को संबोधित करूं और अपने विचारों से आपको परिचित कराऊं। मैं डॉक्टर नहीं हूं, जैसा कि आप लोग डॉक्टर हैं। मैं हिंदी का विद्यार्थी हूं और स्कूल ऑफ ह्यूमैनिटीज में प्रोफेसर हूं, और मैं उसी दृष्टि से बात करूंगा। एक साहित्यकार होने के नाते साहित्य को जिस रूप में मैं देखता हूं, और उस रूप में कैसे जो हमारी पृथ्वी है और हमारा स्वास्थ्य है, उसके बारे में किस तरह से हमारे साहित्य में चर्चा की गई है, और लगातार इस संदर्भ में प्रकृति को अपनी प्रेरणा का स्रोत माना है हमारे साहित्यकारों ने। देखिए, जब हमारा जो हेल्थ सिस्टम है वो बहुत ज्यादा विकसित नहीं था, या कहें कि सीमित क्षेत्रों में था, कम्युनिकेशन की बहुत दिक्कतें थी, हम लोग एक क्लोज सोसाइटी में रहते थे, और हर एक गांव का अपना एक चिकित्सक होता था जो जड़ी बूटी से और आसपास के संसाधनों से शल्य चिकित्सा ऑपरेशंस भी करता था और बीमारियों का इलाज भी करता था। लेकिन सबसे बड़ी बात कि हमारे जितने भी चिंतक हुए, जितने भी ऋषि मुनि हुए, उन्होंने इस बात को समझ लिया था कि ये जो हमारा प्लैनेट है, ये जो हमारी पृथ्वी है, वो पृथ्वी एक अनूठी पृथ्वी है, अनूठा ग्रह है ये, जहां पर हवा भी है, पानी भी है, पेड़ भी हैं, खाने के लिए अन्न भी है, और वो तमाम सुविधाएं हैं जिससे जीवन उत्पन्न भी हो सकता है और जीवन सुरक्षित भी रह सकता है। ये बड़ा नायाब ग्रह है, क्योंकि अभी तक हम यह स्थापित नहीं कर पाए हैं कि और भी किसी ग्रह पर हमारे जैसे प्राणी भी रहते हैं। इस पर फिक्शन बहुत बने हैं, इस पर हाइपोथेसिस बहुत हुई है, लेकिन अभी तक कुछ वैसा प्राप्त नहीं हुआ। तो क्यों है हमारी पृथ्वी नायाब? क्यों है हमारा जीवन सबके जीवन से अलग? हमारे यहाँ तरह तरह के पशु पक्षी भी हैं, हमारे यहाँ मनुष्य भी हैं, पेड़ पौधे भी हैं, और इनके बीच एक सामंजस्य भी। हमारे ऋषि मुनियों ने कहा कि जब तक इनके बीच एक सामंजस्य रहेगा तब तक यह पृथ्वी सुरक्षित रहेगी। आप लोग सब इस बात से परिचित हैं कि पृथ्वी का निर्माण अचानक नहीं हुआ। यह भी एक गर्म पिंड था और धीरे धीरे इसको ठंडा होने में वक्त लगा। कई विस्फोट हुए इसमें, पहाड़ बने, नदियां बनी, समुद्र बने, और तब बहुत दिनों के बाद मनुष्य का जीवन हुआ। इसीलिए हमारे ऋषि मुनियों ने सबसे पहले अपने किसी भी काव्य को लिखने से पहले ईश्वर की आराधना की, और ईश्वर की आराधना के साथ साथ उन्होंने प्रकृति की आराधना की, पृथ्वी की आराधना की, जल, वायु, वृक्ष, पशु पक्षी, सूरज, चांद, नक्षत्र, सभी को अपने साथ लेकर चलने की बात। और आज हम जिस बात पर बार बार नियम और कानून बनाने की बात करते हैं, जैसे वृक्षों को बचाना, पशु पक्षियों को बचाना, पूरे पर्यावरण को बचाना, भाव पैदा हो और हम इनका सम्मान करें, पेड़ों को नहीं काटें, जल को प्रदूषित नहीं करें, वायु को प्रदूषित नहीं करें, सूरज, चांद और नक्षत्र की पूजा अर्चना करें। हम लोग सब जानते हैं कि अगर सूरज चांद न हो तो हमारा जीवन भी न हो। पृथ्वी की जो भूमिका है पूरे ब्रह्मांड में, वह एक महत्वपूर्ण भूमिका है। लेकिन अब विश्व स्वास्थ्य दिवस पर इस पर चर्चा करने की बात क्यों उठी? क्यों हम थीम 2022 में आवर प्लैनेट आवर हेल्थ पर बात कर रहे हैं? क्योंकि हम उल्लंघन कर रहे हैं, प्रकृति का उल्लंघन कर रहे हैं, जल को प्रदूषित कर रहे हैं, वायु को प्रदूषित कर रहे हैं, वृक्षों को काट रहे हैं, पशु पक्षियों को मार रहे हैं, और इससे सूर्य की रोशनी भी कभी कभी हम तक पहुंचने में परेशान हो जाती है जब हमारे यहां इतना प्रदूषण हो जाता है। अब सवाल उठता है कि इसको हम कैसे संभालें। निश्चित रूप से अगर हम अपनी पृथ्वी को और पृथ्वी पर जो सह अस्तित्व में जो जीवन है उसको संभालने का सबसे बड़ा जो हमारे पास उपाय है, वह उपाय है सह अस्तित्व का। और यह सह अस्तित्व केवल व्यक्तियों के बीच नहीं, बल्कि प्रकृति के साथ सह अस्तित्व और आसपास जितने भी जीव जंतु हैं उसके प्रति सह अस्तित्व। और इस मुहिम में आज हम इकट्ठे हुए हैं कि अभी हमारी पीढ़ी ने और जो युवा पीढ़ी है उसने भी ये देखा कि किस तरह हम पिछले 250-300 वर्षों से हम बिल्कुल परेशान हैं। हमारे भीतर एक भय समा गया है अपने जीवन को लेकर, और ये जो पैंडेमिक फैला और उस समय उसमें अचानक हमारी पूरी जो स्वास्थ्य का ढांचा है वो चरमरा गया। आपको वो दृश्य याद होंगे कि लोग ऑक्सीजन सिलेंडर के लिए लाइन लगाए होंगे। आपको याद होगा कि अस्पतालों में बेड नहीं मिल रहे हैं लोगों को। संबंधों पर, मानवीय संबंधों पर इसका असर मिला। अपने अपनों से मिलने से डर रहे हैं। आज हम एक दूसरे से दूर बैठे हुए, पास जाने में भय लगता है। तो ये जो समरसता समाज की है, वह समरसता टूटी इस दौरान कि हम जहां एक दूसरे को गलबहियां लगाया करते थे, लोगों से हाथ मिलाया करते थे, आलिंगन किया करते थे, प्रकृति ने कहा कि नहीं, बहुत अत्याचार किया तुम लोगों ने, इसलिए दंड मिलना चाहिए। और दंड किसको मिलेगा ये हमें पता नहीं, यह प्रकृति ने ही निर्धारित किया। और हम में से कई लोग हमें छोड़कर चले गए। हमारे घर में, हमारे पड़ोस में, हमारे विश्वविद्यालय में, पूरी दुनिया में हाहाकार मच गया ये कोरोना नामक एक संक्रामक बीमारी से। तो सबसे पहले तो हमें स्वस्थ रहना सीखना होगा, और अगर स्वस्थ रहना सीखना है तो हमें अपने खान पान पर भी ध्यान देना। जिस तरह से इलेक्ट्रॉनिक मीडिया ने हम लोगों के जीवन में प्रवेश किया है, और आप लोग विद्वान हैं, सुनीला जी ने और राजेश कुमार जी ने इस पर जरूर काम किया होगा कि हमारे बच्चों की मानसिक स्थिति इस समय क्या हो। बच्चे 3 साल से अपने स्कूल नहीं गए, कॉलेज नहीं गए, वहां उनको पीयर ग्रुप नहीं मिला, और आज बच्चे अकेलेपन में जीने के लिए अभिशप्त है। ये क्या है, और ये क्या है जिसको हम लोग, इस पर भी हमारे विशेषज्ञ चिकित्सक जो यहाँ उपलब्ध हैं, उन्होंने इस पर भी ध्यान दिया होगा। कई रिसर्च भी लगातार चल रहे हैं कि जो भोजन है हमारा, वह भोजन किस तरह से हमारी युवा पीढ़ी को प्रभावित कर रहा है, जिसको हम लोग जंक फूड कहते हैं। वो जंक फूड कितनी तेजी से घर में प्रवेश कर रहा है। अब आपको बाजार नहीं जाना है, अब आपको अपने मोबाइल के द्वारा ही उस जंक फूड का ऑर्डर दे देना है, और वो आपके घर में प्रवेश कर जाता है। और नई पीढ़ी तो पागल है इसके पीछे। उन्हें घर की दाल, घर का चावल, घर की रोटी पसंद नहीं है। उन्हें तो बाहर से मंगाया हुआ वही, ये कोई खाने की चीज है, लेकिन बर्गर, पिज्जा और भी जो चीजें हैं, खाएं जरूर, खाने के लिए कोई रोक नहीं है, लेकिन उस ऊर्जा, जो कैलोरी आपके भीतर जा रही है, उसको निकालने का भी तो अवसर होना चाहिए। तो दौड़ने धूपने का वक्त नहीं है किसी के पास, और इस कोरोना ने तो उस सारे सामंजस्य को समाप्त कर दिया, न हम सुबह को सैर में जा सकते हैं। बार बार ये चेतावनी आती है कि बहुत प्रदूषण हो गया है, इसलिए जो सीनियर सिटीजन्स हैं वो कम से कम बाहर सैर के लिए ना निकले, वह उसके लिए नुकसानदेह होगा। अगर हम खुली हवा में सांस नहीं ले सकते हैं, अगर हम सुबह की सैर नहीं कर सकते, अगर हम अपने दोस्तों से बातचीत नहीं कर सकते, बहुत फर्क पड़ा संबंधों पर। मोबाइल और इंटरनेट ही सहारा बन गया, लेकिन ये जो फिजिकल डिस्टेंस कहा गया, वो फिजिकल डिस्टेंस ने मेंटल डिस्टेंस पैदा कर दिया। और इससे जो मानवीय, बहुत सारी कहानियां लिखी गई इस पर, बहुत सारी कविताएं लिखी गई। मनुष्य भयभीत है, उसके भीतर भय का साम्राज्य है। इसलिए हम सबको मिलकर इस बात का प्रयत्न करना चाहिए कि यदि हम अपने से ही लें, व्यक्ति के रूप में ही लें, व्यक्तिशः ही लें, कि यदि हमको अपना जीवन बचाना है तो सबसे पहले जो आसपास का पर्यावरण है उसको बचाना होगा। छोटी छोटी बातें होती हैं जिनके बारे में हम अपने बच्चों से बात करते हैं लेकिन खुद पालन नहीं करते। पानी को बचाओ, हवा को बचाओ। अब तो मुझे ये लगता है कि बहुत लंबा समय नहीं है जब हमें अपने साथ मोबाइल ही नहीं, लैपटॉप ही नहीं, बल्कि ऑक्सीजन का सिलेंडर भी लेकर चलना पड़ेगा। और हम एक और वो भी बहुत दिन नहीं चल सकता है। इतने ज्यादा इलेक्ट्रॉनिक गैजेट बन गए हैं कि बहुत अच्छी बात है, हम अपने घरों में बैठकर ठंडी हवा खाते हैं और सारे वातावरण को ग्लोबल वार्मिंग से भर देते हैं। इसका भी कुछ रास्ता अपनाना होगा। लोग सचेत हो रहे हैं, लोग जागरूक हो रहे हैं, लेकिन और जागरूक होने की जरूरत है। हमें अभी सावधान रहने की जरूरत है ताकि स्वस्थ भोजन करें, पौष्टिक भोजन करें, अपने को मजबूत रखें। जो हमारे घरेलू नुस्खे हैं उसको अपनाएं। ये सारी चीजें जो हैं वह हमें स्वस्थ रखेगी और हम स्वस्थ रहेंगे तो सब कुछ स्वस्थ रहेगा। तो मैं इस कामना के साथ, इस विश्वास के साथ कि इसके बारे में हमारे विशेषज्ञ हमारे प्रेरणा का स्रोत बनेंगे, हमें बताएंगे कि किस तरह से हमें अपना जीवन व्यतीत करना है, कौन कौन सी सावधानियां रखनी है और किस प्रकार हम एक संतुलित जीवन जी सकते हैं। तभी हमारा ये प्लैनेट सुरक्षित रहेगा और हम स्वस्थ रहेंगे। एक बार फिर मैं स्कूल ऑफ हेल्थ साइंसेज को और निदेशक प्रोफेसर पीटी कौल को बहुत बहुत धन्यवाद देता हूं, मुझे ये सम्मान प्रदान करने के लिए कि मैं अपनी भावनाओं को व्यक्त कर सकूं। और दोनों विशेषज्ञों को मेरा बहुत बहुत नमस्कार और स्वागत। धन्यवाद।
Thank you very much, sir, for a very simple and sweet discussion and detailed responsibilities which as a citizens we all have, whether we are in the capacity of an individual, part of an organization, part of healthcare system. These you have briefed us in a very simple and very sweet words that what action we should take, and all these actions are included in the WHO charter also related to the theme which you have spoken. Thank you very much, sir, for sparing your precious time with us and enlightening us with your ideas. With this, I would now request Dr. Suneela Garg kindly speak on the theme, our planet, our health.
धन्यवाद ऑनरेबल वाइस चांसलर, ऑनरेबल प्रो वाइस चांसलर, निदेशक डॉक्टर प्रीति कौल, and facilitator and coordinator of this program, Dr. Rita. I'm very thankful, basically to IGNOU for providing me this opportunity. And मैं हिंदी में ये कहना चाहूंगी कि जो हमारे प्रो वाइस चांसलर डॉक्टर सत्यकाम ने जो विचार प्रकट किए कि प्रकृति के उल्लंघन, नियमों का उल्लंघन करने के लिए हमें आज भुगतान जो करना पड़ रहा है, तो ये बहुत जरूरी है कि हम टाइमली एक्शन लें। हम अपने प्लैनेट के प्रति, हम एयर के प्रति या वाटर के प्रति हम जितनी बातें करें या फूड के प्रति, तो ये बहुत इंपॉर्टेंट है कि ये अभी हमें सतर्क होने की जरूरत है। स्पेशली हम बहुत डिफिकल्ट टाइम से गुजरे हैं, पेंडेमिक टाइम से, जो कि पर्टिकुलरली अब आज हम कहते हैं कि हमारे लो नंबर ऑफ केसेस हैं, परंतु मैं ये जरूर कहना चाहूंगी कि हमें बहुत ध्यान रखना पड़ेगा आगे भी, फॉलोइंग द अप्रोप्रिएट बिहेवियर, क्योंकि बिहेवियर चेंज बहुत मुश्किल से आता है। सो विद दिस आई विल, मैं अपना शेयर स्क्रीन करूंगी और मैं थोड़ा सा अपना बताऊंगी वर्ल्ड हेल्थ डे के विषय में। और मुझे टाइम 45 मिनट्स का दिया गया है एज पर द शेड्यूल, तो आई विल जस्ट ट्राई दैट आई विल स्टिक टू द टाइम दैट विल बी देयर। एंड जैसा कि हम सब जानते हैं, मेरी स्लाइड्स विजिबल है सबको?
यस।
I'll call you later. Meeting. I'll call you later. So basically World Health Day हम सब लोग 7 अप्रैल को मनाते हैं to mark the anniversary of founding of WHO in 1948, because it is seen as an opportunity by the organization to draw worldwide attention to a subject of major importance to global health each year. The first World Health Day was celebrated and observed on 7th April 1950. Since then, it is celebrated every year on the same day. Each year, the theme is selected to highlight a priority area. And this year, the theme is Our Planet, Our Health. And we are focusing on clean our air, water, and food for a healthier tomorrow, as has been amply highlighted by, Madam also and by our Honorable Pro Vice Chancellor. Two main focus of, basically WHO this World Day 2022 are to keep the humans and planet healthy, to foster a moment to create societies which are focused on well-being. The theme of this year World Health Day, Our Planet, Our Health, Clean Our Air, Water and Food, is a priority area of concern for World Health Organization, which is based on the understanding that humans, animals, and the environment are linked together, indicating that the world has suddenly realized the interrelation between animal diseases, public health, and ecology. Because keep in mind that animal diseases are also equally important because they are closely linked to us. Hence, striving to restore and maintain harmony and synergy is the need of the hour. So 3 main questions are raised by WHO on this World Health Day. Are we able to reimagine a world where clean air, water, and food are available to all, where economies are focused on health and well-being, where cities are livable and people have control over their own health and health of the planet? And basically, we all know all these issues, amongst COVID-19 pandemic, polluted planet, and increasing diseases like cancer. That is where these 3 questions have been raised on the occasion of World Health Day 2022. And also we know that, WHO defines health as a state of physical, mental, and social well-being, not merely the absence of disease or infirmity, to which we have added a spiritual component as well. We all know, you can see on my, in the picture below, that where the well-being program focuses on all, that is whether we talk of environmental health, intellectual health, occupational health, physical health, social or spiritual or emotional health, and also overarching is your financial health. To respond to these questions on health and well-being, there are various governmental schemes and programs launched by Government of India, and some of these programs have been National Health Mission, under which we have National Rural Livelihood Mission, that is NRLM, and National Urban Livelihood Mission. That is important. So these are
Recording in
very,
progress.
very, very important things which we have to keep in mind. And then if we have to focus on sustainable development goals, the first important goal is to reduce the global maternal mortality ratio to less than 70 per 100,000 live births. Currently, we have got 103. And then also we have to have, end the preventable deaths of newborns and children under 5 years of age, aiming to reduce neonatal mortality to at least 12 per 1,000 live births and under 5 mortality rate to at least 25 per 1,000 live births. By
Madam,
2030,
excuse me, madam, the slides are not moving. Ma'am. Slides are not moving.
so how do I stop share and do again?
No, they are all, the slides are shared, but they have to be moved. Arrow.
Just a minute. No, I'm doing the arrow.
But it's not,
Yeah.
only the first slide is coming.
No, just a minute. Is it okay now? Can you see the third slide? Are they,
No, please click on the third slide.
no. Are they moving now?
No, only first slide is there. On this side. Karo to carry, madam. Yes, madam. Now you can click. Now the background, yes.
It is moving now?
Yes.
No, but then if I put it on slideshow, they don't move.
So now it is introduction. Then the other slide has come. You have to click the slide.
No, madam, I'm clicking. I'm used to all.
Maybe you can just increase the magnify it a little bit from below. जहाँ 74% लिखा है मैम, उसको थोड़ा सा ज्यादा कर दीजिए.
Okay, ठीक है.
No, it has become, yeah, just that's it. No, you can just, yes ma'am, 82 तक कर दीजिए, that's it.
F5 प्रेस कर सकते हैं.
नहीं, वो तो मैं कर रही हूँ, तो उससे नहीं हो रहा ना.
But नहीं, ये तो अभी तो ठीक है, मूव कर रहा है. It's all right now. अब मूव तो कर रहा है अभी. Yes.
So to start with that, we decided we focus on the health as a state of physical, mental, social, and spiritual well-being. And now, we have got sustainable development goal targets also. So we have to, by 2030, we have also got to end the epidemic of AIDS, tuberculosis, malaria, and neglected tropical diseases, including, we have hepatitis, waterborne diseases, and other communicable diseases. By 2030, we have to reduce 1/3 of premature mortality from non-communicable diseases through prevention and treatment and promote mental health and well-being. Another thing is we have to strengthen the prevention and treatment of substance abuse, including narcotic drug abuse and harmful use of alcohol. By 2020, we have to halve the global deaths and injuries from road traffic accidents. And by 2030, we have to ensure universal access to sexual and reproductive healthcare services, including the family planning, information and education, and integration of reproductive health into national strategies and programs. And we have to achieve universal health coverage, including financial risk protection and access to quality essential healthcare services and access to safe, effective, quality and affordable essential medicines and vaccines for all. And by 2030, we also have to reduce the number of deaths and illnesses from hazardous chemicals, air, water, and soil pollution and contamination, which is one of the goals of the World Health Day today. And when we talk of the means of implementation, we also have got a WHO's FCTC, that is Framework of Convention of Tobacco Control, which we have got to strengthen in all countries as appropriate. And we also have to support the research and development of vaccines and medicines and make them, accessible and affordable to all. And another thing is that, which has been pointed out in 3.C, is that we have to substantially increase health financing and the recruitment, development, and also training and retention of health workforce in the developing countries, especially in the least developed countries and the small island developing countries. And also, we have to focus on increasing and strengthening the capacity of all countries, in particular the developing countries, for early warning, risk reduction, and management of national and global health risks. Another important point, so this slide basically sums up, what I talked earlier, but one of the important things which you have to remember, that we still have, lot of, many miles to go, because we still have stunting rates, children which are there, though they have declined by almost 10%, but still NFHS data 5 has shown that it is quite very high. Maternal mortality ratio has shown significant decline, but it is also 103 per 100,000 live births. We also know that 2.1 million people are living with HIV/AIDS. Over 1/4 of the tuberculosis cases, they occur in India with 4,23,000 deaths annually. And also we are dealing with, lot of problem of malnutrition and stunting. So also, we now have National Health Mission. The objective of this program is to provide accessible, equitable, affordable, and quality healthcare. Remember that we are talking of not only to the rural population, we are talking to urban population and especially to vulnerable groups. Our National Health Mission is focusing on establishing a fully functional, community-owned, decentralized healthcare system. So now we are reaching the last mile under Ayushman Bharat, so that the purpose of the mission is to ensure simultaneous action on a wide range of determinants of health, such as water, sanitation, education, nutrition, social and gender equity, as well as equality. And another thing which is very, very important is that then when we talk of RMNCHA, which is a strategic approach to reproductive, maternal, child health and adolescent health in India, and we know that this framework was adopted in 2013, which aims to address the major causes of mortality and morbidity amongst women and children. And this framework also helps us to understand delays in accessing and utilizing healthcare services. And if you look at some of the key indicators, maternal mortality ratio, as I was telling you, that our national health policy target was 100 by 2020, now it is 103. Neonatal mortality rate 16 by 2025. And sustainable target is, the SDG target is less than 12. Infant mortality rate is 28 by 2029 and current status is 33. Under 5 mortality rate, current status is 37 and we have got to go to 23 by 2025 and total fertility rate is 2.2. So we have got national policy level is that we have to reach the replacement level of fertility. So in fertility indicators, we have done quite well and we have achieved almost the population stabilization. So one of the initiatives which is Government of India's initiative is Suman, which we call it as Surakshit Matritva Abhiyan, which aims to provide assured, dignified and respectful quality healthcare. So which is aiming at preventing. WHO now says 8 antenatal checkups, but it also focuses on normal delivery, which is a major area of attention now. And with the only required number of C-sections, we also have to provide medicines, lab tests for mother from conception to 6 months after delivery and baby up to 1 year, proper care with dignity and respect, and also grievance redressal mechanism with toll number 104, and all the available services are free of cost. Now, I will be pointing out at, other areas of Government of India, which is Janni Suraksha Yojana, Janni Shishu Suraksha Karyakram, or also, if you look at Lakshya program, which is aimed to provide quality of care in the labor room and maternity operation theaters to mitigate those risks. So India is currently on track to achieve SDG Goal 3, target of MMR below 70 by 2030. So that's why I said that currently we are 103 in number, but there are a lot of inequalities. If we look at some of the key indicators of NFHS 5 in 5 union territories of India, I will point out that 2 mothers with 4 antenatal checkups declined in an NFHS 5 to 83.4%. If we are looking low antenatal, 4 antenatal checkups declined to, basically 81.2%, as compared 81.2%, and in NFHS 4 to 80.9%. That is important point. So 81.2% was there in NFHS 4 and 80.9% was there in NFHS 5. Mothers who consumed iron and folic acid for 180 days. This is an area of concern when we talk of, essential supplementary, nutrition, particularly iron and folic acid. This has declined to, 15.9%. This is, or rather only 15.9% of the women have been taking, iron and folic acid. Another thing which is very important is if you look at Ladakh, mothers with 4 antenatal checkups declined in NFHS 5. That is 87.4% in NFHS 4 to 78.5%. That is important. Mothers who consumed iron and folic acid for 100 days were only 14.3%, whereas those who consumed for 180 days were only 7.3%. So this is another area of concern which you have to keep in mind. Not able to move my slides. Is my slide visible? Can you see the slide, please?
Yes, ma'am. Yes, ma'am.
Yeah. So if we look in, the other inequalities in Lakshadweep, mothers with 4 antenatal checkups increased in NFHS 5, 82.3% in as compared to, basically NFHS 4, 88.3%. That is where when we talk of NFHS 5 to basically it increased in NFHS 4 from 80.3% in NFHS 4 to 88.3%. But mothers who consumed iron and folic acid for 100 days were 80.1%, whereas those who consumed for 180 days was 61.7%. And if we look at Dadra and Nagar Haveli, also, basically we looked at in NFHS 5, basically they increased to 86.4%. That is another thing. And but the point of concern is that mothers who consumed iron and folic acid for 100 days were 50.9%, and those who consumed for 180 days were only 36.2%. That is another important area which we have to keep in mind. So the slides don't move. So if we look at some of the other key indicators in 7 northeastern states of India, one important thing is that mothers, with 4 antenatal checkups, they look at the meager number. That is important. They moved only from, 46.4% in NFHS 4 to 50.7%. Mothers who consumed iron and folic acid for 100 days were 47.5%, whereas those who consumed for 180 days were 18.5%. If you look at the state of Mizoram, mothers with 4 antenatal checkups decreased in NFHS 5, that is 61.4% in NFHS 4, basically to 58%. And mothers who consumed iron and folic acid for 180 days were 10.5%, though basically we knew that institutional births were quite okay in 85.8%, but children who received postnatal care were only 36.9%. In Meghalaya, mothers with 4 antenatal checkups will increase slightly from, it's already a very less number, 50% to 50.2% is not a major difference. We have to aim at, almost 100%. And mothers who consumed iron and folic acid for 100 days were 43.1%, whereas those who consumed for 180 days were 20.6%. And whereas in Sikkim, if we look at mothers with 4 antenatal checkups decreased, basically from 74.7% to 58.4%. So this is a area of concern. And mothers who consumed iron and folic acid for 180 days were only 31.5%. And institutional births were though 94.7%, but children with with postnatal care were only 44.9%. So these are the areas which again deserve attention. If I look at some of the key indicators in NFHS 5 of 5 states in central and western India, if you look from that perspective, if you look in Bihar, mothers with 4 antenatal checkups increase in NFHS 5 versus NFHS 4. Look at the increase, only 14.4% received in NFHS 4 to 25.2%. Mothers who consumed iron and folic acid for 100 days were 18%. So these are the things which deserve attention of inequitable distribution, whereas those who consumed for 180 days was only 9.3%. Whereas in Himachal Pradesh, if we look at NFHS 5 versus NFHS 4, it is basically, it is increased from 69% to 70.3%. And when mothers who consumed iron and folic acid for 100 days were 67.2%. Again, for 180 days consumption is, so this is an area of concern, 43%. And another thing which is very important is that here, substantially better number of women received postnatal care, that is 86%. And in Gujarat, when we talk of 4 antenatal checkups, basically we are talking of, they increased to 76.9%. Again, in a good state like Gujarat, we have got only 76.9%. But mothers who consumed iron and folic acid for 180 days was only 43.2%. Institutional births were 94.3%, postnatal care 88.7%. But all the indicators were better in urban areas as compared to rural areas when we look at this fact. Another thing which is very important is that in Maharashtra, we looked at the 4 antenatal checkups that declined from 72.2% to 70.3%. Again, iron and folic acid consumed for 180 days was only 30.9%. In Goa, you can see that NFHS 5 showed a slight increase from 89 to 93%, but this is a good performing state. So if you look at the difference between Maharashtra and Goa, there is a difference of almost 23%. And mothers who consumed iron and folic acid for 100 days were 87.5%, whereas those who consumed for 180 days was only 65%. Mothers who received postnatal care from any person was 95.4%, but institutional births have been substantially very high in Goa, 99.7%, and children who received postnatal care were 96.7%. So this is one of the important areas and states to be appreciated also. Another thing which is important is that you can look at, similarly, Karnataka, we are looking at 70.1% of the, antenatal checkups, whereas in Kerala, it is, this is another remarkable thing which I want to bring to your attention. In a good performing state, it has decreased from 90.1% in NFHS 4 to 78.6%. We always counted Kerala as a very good performing state. But mothers who received, iron and folic acid and consumed for 180 days was 67.67%. Though institutional births are 99.8%, but postnatal care is 91.2%. But still, the area of concern is declining number of antenatal checkups. Another thing which is fact about hunger, Global Hunger Index, in 2020, India ranked at 101 out of 116 countries. Look at the ranking on the basis of 3 leading indicators, that is prevalence of wasting, stunting of children under 5 years, and also, under 5 mortality rate and proportion of undernourished in the population. According to Food Agriculture Organization estimates in the State of Food Security and Nutrition in the World 2020 report, 189.2 million people are undernourished in India. By this measure, 14% of the population is undernourished in India, and also 51.4% of the women are anemic. That is important, and that has already been pointed out in NFHS 5 as well. So if we talk of, Sustainable Development Goal, zero hunger. So Sustainable Development Goal number 2 is directly linked with food, which is a part of World Health Day theme this year. And it talks about zero hunger. The goal is to achieve food security and improve nutrition and promote sustainable agriculture. 2 billion people in the world do not have regular access to safe, nutritious and sufficient food. And 2019, 144 million children under the age of 5 were stunted and 47 million were affected by wasting. This is a UN report which is important and to be considered very, very seriously. Another thing which is very important is that when we talk of, ending hunger, achieving food security, and improve nutrition and all. And basically, if you look from that perspective, according to UN report, 80 to 21 million people regularly go to bed hungry in the world, of whom 100 plus million they suffer from acute hunger, which is due to man-made conflicts, climate change, and economic downturn. So this is what we are facing in the world today. And already, we have got examples of, countries like Ukraine and Russia and Sri Lanka in our neighborhood. As the world has to face unprecedented situation of COVID-19, it is important to make sure that people who are already on the verge of starvation do not succumb to this virus or to its economic consequences. And also we know that, during COVID-19 pandemic in 2020, Pradhan Mantri Garib Kalyan Ann Yojana was started to provide additional ration of 5 kgs of wheat or rice per person and 1 kg of pulses per household every month, free of cost to 80 crore beneficiaries, basically under NFSA. Another thing is, however, in 2021, the scheme was restarted when only wheat and rice was provided. Hence, the Right to Food campaign is demanding an extension of the scheme till May 2022 with the provision of edible oil and pulses, which is basically a source of protein to each household. Another thing which we have to keep in mind is that concerns which are related to, food are basically, despite India having a basket of food safety programs like midday meal or ICDS services or public distribution system, there is increase in percentage of children under 5 years who are overweight also and severely wasted also. So we are looking at, basically we are facing a dual burden. One is a burden of overweight, another is a burden of wasting. The level of hunger in India has been called serious, with the overall score of 27.5, and India ranks, I already told you, 101 out of 160. Now, also Sustainable Development Goal India Index Dashboard 2021, Partnerships in Decade of Action, prepared Niti Aayog states that 33.4% children aged under 5 are underweight and 34.7% are stunted. So this is one of the important things too, and that is where we have got Right to Food campaign as well. So another thing which we have to keep in mind is that India's nutrition status as per NFHS 4 and 5 is that basically, the India's own NFHS reflects the gravity of malnutrition in the country. And we all know that basically, though, there is 3% decline in child stunting from 38.4 to 35.5, but still the problem is grave. Though today it has been in the news by Smriti Irani that the survey is done by 1 crore population, where 2% children have been found to be wasted. But from a public health perspective, I will like to say that a whole sample has to be representative of the total population, and we have to keep in mind. So children under the age of 5 years who are overweight, which have increased from 2.1% to 3.1%, it is that is 1.3% rise, is also an issue of concern which we must keep in mind. Another thing which is very important is that when we talk of food and health initiatives, we have got Sakshan, Anganwadi and Poshan 2 Abhiyan, under which we are strengthening the nutritional content, delivery, outreach and outcome of the services, along with supplementary nutrition program Poshan Abhiyan, which we launched also now recently. Poshan 2, Saksham Anganwadi and Poshan 2 covers the integrated child development services scheme. So all have been prepared now. Instead of Poshan, we are talking of Poshan 2 as well, where we are creating Saksham Anganwadis to provide supplementary nutrition, and we are also addressing the adolescent girls under this. And also Pradhan Mantri Matritva Suraksha Yojana have also got, this Smartha initiative for the women, and under which, we are basically making women empowered as well. And then under public distribution scheme, we are offering food and non-food items like wheat, rice, salt, pulses, spices, and kerosene oil to the poor at a subsidized rate. In its demand note, the Right to Food campaign has called to universalize the public distribution system to give subsidized ration to everyone who demands it. So that is another. So we are all aware of another initiative, that is Anemia Mukt Bharat, where there are many causes of anemia, out of which iron deficiency anemia is accounting for 50% of the anemia in school children and women of the reproductive age group. So that is important point to remember, and that is where we have started this Iron Plus initiative, and other nutritional deficiencies besides iron, such as vitamin B12, folate, and vitamin A, can also cause anemia. Although the magnitude of their contribution is unclear, but particularly we are also addressing the issues of malaria, helminthic infections, TBs, and hemoglobinopathies, which where they are important for high causes, important cause. They account for high prevalence of anemia, and these issues are being addressed as well. Another thing which is important is that we are addressing, through National Deworming Day, we are taking care of National Vector-borne Disease Control Program, addressing malaria and all that, and also addressing hemoglobinopathy. And we do have, our backbone document, National Health Policy, as well as National Nutrition Strategy, which is the guiding principle for addressing these issues. And basically, we are also, Government of India is committed to the World Health Assembly target of 50% reduction of anemia amongst women of reproductive age by 2025, and the Poshan Abhiyan 2018 to 2020 target to reduce prevalence of anemia amongst children 6 to 59 months and adolescent and women of reproductive age to 15 to 49 age group by 3 percentage points per year. So that is important point to remember. And Poshan Abhiyan, or National Nutrition Mission, is Government of India's flagship program to improve nutritional outcomes for children, pregnant women, and lactating mothers. And this directs the attention of the country towards the problem of malnutrition, and it has to be addressed in mission mode. And for this, we have got 4 pillars. One is intersectoral convergence for better service delivery, use of technology for real-time growth monitoring, intensified health and nutrition services. And another important thing is Jan Andolan, which is a very important initiative. Another thing is that we also observed Poshan Ma in 2018, where we focus on all the issues like antenatal care, optimal breastfeeding, complementary feeding, anemia, growth monitoring of girls, education, diet, right age at marriage, hygiene, sanitation, eating healthy, and food fortification. How can we achieve zero hunger? Zero hunger can positively impact our economies, health, education, equality, and social development. And it requires a multidimensional approach, from social protection to safeguard safe and nutritious food, especially for children, to transforming food systems to achieve a more inclusive and sustainable world. There will be there is a need to have investments in rural and urban areas and in social protection, so that poor people have access to food and can improve their livelihoods. To help, we can make changes in our own life at home, at work, and in the community by supporting local farmers or markets, and making sustainable food choices and supporting good nutrition for all. Another important thing is we need to have accessibility to water, and we have got goal 6 to ensure access to water and sanitation for all. And WHO on this World Health Day gives emphasis on clean water, and clean water is critical for survival, and its absence can impact basically the health, food security, and livelihoods of family. So we must have access to all and address not only information about clean water, but also hygiene, education, and good sanitation, and more ways to reuse water, as has been showing. And we also should be monitoring the good water quality regularly. So that is another important point which we have to keep in mind. So we have got facts about drinking water is that by 2020, 74% of the global population use safely managed drinking water services. That is the one which is located on the premises and available when needed and free from contamination. And globally, at least 2 billion people use a drinking water source contaminated from feces. That is an area of concern. So microbial contamination of drinking water as a result of contamination with feces poses greatest risk to the drinking water quality. So that is important. And we are all aware of transmission of diseases because of contaminated water. So this area has to be kept in mind. So another thing which is very important is that basically we need to have safe and sufficient water, which facilitates the practice of hygiene, which is key measure to prevent not only diarrheal diseases, but acute respiratory infection and numerous infected tropical diseases. And we all know that basically in India, 163 million people do not have access to safe water, and 210 million have lack of access to improved sanitation as of 2017. According to Niti Aayog in 2019, 75% of the household do not have drinking water on the premise, and about 84% of the rural households do not even have piped water access. So that is important part to be remembered in connection of water. So we must preserve every drop of water that is there. So this is one thing which has been focused on, that 2.6 billion people have gained access to improved water since 1990, and 66 million people are without water still. That is there. So this is where our main access is by 2030 to have universal, equitable access to safe and affordable drinking water for all. So under which we have got, adequate, equitable distribution, improve the water quality, reducing pollution, and also substantially increase the water use efficiency across all sectors. We have to have integrated water resources and management at all levels, and expand international cooperation and capacity building, and support and strengthen participation of the local communities in improving water and sanitation. Another important thing is that it calls for universal, equitable, and access to safe and affordable drinking water. That is another point, which we have to keep in mind, as has been pointed out by Pro-VC in morning as well. And we have, under this several governmental programs like Swachh Bharat Abhiyan. We have also got National Rural Water Program and Jal Jeevan Mission, which was launched in 2009, which aims to provide safe and adequate water for drinking, cooking, and other domestic needs to every rural person on a sustainable basis. And since August 2019, Government of India in partnership for states is implementing this Jal Jeevan Mission after subsuming erstwhile National Rural Drinking Water Program to make provision of potable water at a service level of 55 liters per capita per day to every rural household through tap water connection by 2024. So this is important part we have to keep in mind. Another thing which is very important is that we do have a lot of challenges also. We have a challenge of, the climate. We do have a challenge of, over 2 billion people are living in water-stressed countries, which is important. Another thing is that the climate change is going to lead to, greater fluctuations in harvested rainwater, and management of all water resources will need to be improved to improve water, provision as well as quality. Another thing we have to see in mind is with regard to, or we have to keep in mind is with regard to ecology and health. 13 million deaths across the world each year are due to avoidable environmental causes. The environmental or the climate crisis, which is the single biggest health threat facing humanity, climate crisis is equivalent to health crisis. Over 90% of the people breathe unhealthy air resulting from burning fossils and fuels. Heating world, causes increase in mosquitoes and diseases caused by it. The systems that produce highly processed, unhealthy foods and beverages are driving a wave of obesity, increasing cancer and heart disease, while generating a greenhouse emissions as well. So basically, air pollution, which is one of the world's biggest environmental risks to health, must be addressed on a priority basis as it continues to rise, causing long-term diseases and illness, in addition to 800,000 deaths per year in Southeast Asian region. And then moreover, growing industrialization leads to soil and water pollution in view of large-scale use of chemical fertilizers, insecticides, and pesticides, which lead into a groundwater and making it polluted as well. So if we talk of ecology and health and climate crisis, few of the important factors are extreme weather. We have to look at the, sorry for the spell mistake over here, land degradation, water scarcity, displacing people, which all affect health. And the Earth's climate is changing with severe consequences for daily life and the resilience for our countries. Climate change is disrupting national economies, and people are experiencing changing weather patterns, rising sea levels, and extreme weather events. And greenhouse gas emissions from human activities driving this change continue to rise. They are now at the highest levels in the country. The poorest and most vulnerable people are being affected the most. And climate change also exacerbates disasters. Combating it is absolutely vital to guaranteeing our survival and well-being for our future generations as well. So this is what the greenhouse emission is, if you look at, from transportation, electricity generation, industry, agriculture, commercial, and residential. But if you look at, the generations in terms of fluorinated gases is 3%, nitrous oxide is 6%, methane is 10%, but carbon dioxide is 82%. That is one thing which needs to be addressed as well. Another thing which is very, very important is, when we talk of India and Sustainable Development Goal 13, which is focusing on, climate action, time is come that where we have to take urgent action to, combat the climate change and its impact. Yeah, without this, the world's average surface temperature is likely to surpass 3 degrees Celsius in the country. So that is another important point which we have to keep in mind. Another thing is that when we talk of, we have to make our cities and human settlements inclusive, safe and resilient and sustainable. That is important. So that is why by 2030, India will have 7 mega cities with population over 10 million. 31% population is living in our urban area. So it is important that we have to focus on the healthy cities concept as well. So another point is that if I'm not going to focus more on the livable cities, but then the framework condition is that we have to have a decent life for all inhabitants of the cities, regions, and communities, including their physical and mental well-being. So lastly, we have to have some of the actions which are focusing what the governments can do. Governments can prioritize long-term human well-being and ecological stability, prioritize well-being in all business organizations, social and ecological goals, stop fossil fuel subsidies, reinvest fossil fuel subsidies to public health, protecting the forests, rivers, oceans, and wetlands, electrify healthcare facilities with renewable energies, and repurpose agricultural subsidies towards sustainable and healthy food production. Another important thing is the governments can reduce air pollution levels to reduce the burden of the disease, tax the polluters, incentivize the carbon reduction, and tobacco pollutes the world and our lungs, and we have to create smoke-free cities and tax the tobacco. So government has to have tax highly processed foods and beverages as well, implement policies to reduce food wastage, and we have to devise policies on waste and plastic reduction and build cities with green spaces that promote physical activity and mental health, and integrate mental health and psychological support with climate action and better policies to better prepare for and respond to climate crisis. In general, when we talk of one planet, one health, we have to focus on that. Ultimately, we have to have an environment where basically we have to focus on the individuals, we have to focus on the societies, we have to focus on the communities. So WHO's 5-point action plan talks about, this is the last slide, walk or pedal to the work at least one day a week, choose public transport. Change to a renewable energy provider, don't heat your rooms over 21.5 degrees. Turn off the light when not in the room. Buy your fresh groceries from the local producers and avoid highly processed food and beverages. Tobacco is a killer and a polluter. Stop consuming tobacco. Buy less plastic and use recyclable bags. And this is what we want to have. Basically, ultimately, we have to focus on a world which is having a sustainable environment. We have to focus on our earth with clean water, clean air, and accessible food for all. Thank you so much. Thank you.
Thank you very much. Thank you very much, madam, for your thought-provoking and enlightening lecture and highlighting whole health system in the country with respect to the states, the performance of the states in various indicators of health, and also the focusing on theme regarding all how to combat the good effects of soil, water, and environmental noise pollution, and so on. So it was very enlightening to hear from you. With this, I would request now Dr. Rajesh to speak on digital technology in healthcare. Dr. Rajesh.
Good afternoon, everyone. First of all, let me express my gratitude to IGNOU for inviting me to deliver this talk on digital technologies in healthcare, opportunities and challenges. I would like to cover these 5 points. The first one, our planet, our health, which is the theme of World Health Day today. And Dr. Suneela Garg has very elaborately described the challenges and what needs to be done. Second is role of digital technologies in healthcare. And then I will take up a case study which we carried out in Chandigarh. We call it INTPART project or International Partnership Project with the University of Oslo and PGI, funded by Norwegian Research Council. And in the experience of implementing this project, we encountered many challenges. So I take up that, and there are several opportunities. And I will conclude by 1 o'clock with the way forward. So as we were discussing our planet, our health, a whole of society approach is needed for this planetary health, and so as to aim to maximize health and well-being for all. And here all includes everything, our beloved earth and all the inhabitants on it. And digital technology is playing an important role in surveillance of the health of this planet and its inhabitants. As you know, now all kinds of weather events are predicted well in advance. Extreme events due to climate change, floods, typhoons, etc. are monitored, and people are getting warning signals, forest cover, desertification. So all the determinants of health are being monitored now with digital technology in real time. So already there is a lot of application of digital technology in the world. Now, in the healthcare field, digital technologies are being used. It was the World Health Resolution in 2018. I hope you are able to hear and see the slides moving.
The slides are not there. Slides are not there. It's not shared. Kindly share the slide.
So from my side, it was shared. Okay, let me just try one more time. I had said this slide share. Okay. Is it visible now?
Yes, yes.
Can you see now?
Yes.
Okay. So anyway, so that was my introduction. So in 2018, the World Health Assembly, India moved a resolution for application of digital technologies in healthcare. And the World Health Organization agreed that there are several opportunities for using digital technologies. And they agreed on these four broad areas. First one is support care at home and in community. Second one is facilitate clinical and consumer decision making. Third one is build providers and consumers knowledge and skills. And fourth is improve healthcare quality and safety. And fifth is improve health information systems. And we saw in the pandemic, the use of technology increased manifold. And in these all 5 areas, we utilized digital technologies in healthcare. And now we have the launch of this Ayushman Bharat digital mission last year. And it was expressed that now we will be using digital, and this mission has been set up and it has been funded also this year. It has started functioning. Now, what is the state of art of digital technology in India? Several initiatives are improving health services using digital technologies. But you see, most of these vertical health programs we have, like HIV, TB, RCH, etc., they use digital technology. for aggregate, sending the reports, and for case-based reporting also. Some of these are Health Management Information System, which is in operation since 2007 with the start of NHM. RCH portal, which was earlier Mother-Child Tracking System. Then another portal is added like for non-communicable diseases, and for TB there is a NICSE. So likewise, there are many portals. Now, Ayushman Bharat Digital Mission has been initiated, and they have set up registries for health facilities. All facilities can register there. All health professionals can also register, and all people can have and prepare their personal health record by having a unique ID also. And there is a proposal to have a unified health interface so that so many hospitals, health centers, so many records, they can talk to each other. But so far, most of the digital programs, they are working in isolation, and we do not yet have a very integrated way of having a health information in the country. All programs, they are work in silos, and we do not have a comprehensive health information system for healthcare. So therefore, realizing this, we actually started a project, as I mentioned, some innovation to use digital technology in an urban primary healthcare setting of Chandigarh. This is an aerial map of Sector 25, which is a resettlement colony. It was a slum earlier, but now about 25,000 people live in very congested, very small houses there. And we had a dispensary, and we tried to use digital technologies to make our services more effective and efficient. So to begin with, for system design, we try to have certain principles. So first principle we used was that it should be a one-point solution for addressing all healthcare needs of community, people, patients, providers, and administrators. So it should cover everything. Number two, it should be very comprehensive, that it should include health promotion, prevention, diagnosis, treatment, and care, all spectrum. And then it should use open and free standards and open and free software, and should have a very low cost and very flexible model, which can be modified by users in future, and on a very decentralized platform. So these were the common, principles which we laid out before we started to have this digital technology used in the health center. So we set up a living lab. This is a concept that living lab is where we work with the community, you see, and we have certain principles and values. That is openness. We have openness. If we have openness, then we have possibility of, work in the given context. And we also use the approach of ecosystem approach, so that if we design things according to the ecosystem, then these things can be scaled up. And choose a technical infrastructure which can last for longer period of time. So we set up this lab there, and the approach in the lab which we had is that there is a role for the users. Those who use the technology, they should have a role, and there should be a spirit of co-creation. Health workers, ASHAs, ANMs, doctors, and technology developers, they work together and create something which is user friendly and is very relevant to the context, and it is evaluated in the real time. So this approach we used, and then we try to have these innovations which we implement in this one health center. So this living lab approach is when you see academics and technology developers and the implementers at the grassroots level, they work together in a real-time basis and come out with innovations rather than the traditional approach that all the research is produced in the lab and then it is taken to the field and many times find that it is not suitable. So the process we adopted in the living lab approach was that initially the engineers, software developers, they also see for themselves the workflows and what are the requirements, and then they make their requirements. In the health field, they are not like one-time requirement. Program change, requirements for reporting also change over a period of time. So that dynamic nature is kept in mind and everything is customized and then testing is done in the real setting. This is how development took place and then it was implemented. So we used two systems which were, as I mentioned, open source and open standard. One of these was DHIS2, District Health Information System, which is used by University of Oslo, and this is an open source, and another one was OpenMRS. So created a register for the household members as a family folder, and then in the family members, whatever services they require for whichever national health program, separately modules for each one of them, like NCD, family planning, maternal health, child health, HIV, TB, death birth registration, likewise. So this was a community health module where preventive and promotive services were, delivered through this. And then the curative services or the clinical module, it was like for registration, for triaging, for OPD, and for pharmacy, lab. And both these systems, they were interoperable and talk to each other so that anybody who come to the clinic, you can know already whatever services they are availed in the community. And same way in the community, when one family member, one can try and see which services they have to be delivered and what kind of problems they had and when did they go for OPD services. And then based on this, the tracking system was developed so that clinicians, they can see how the patient is doing, like multiple widgets are there. So whenever a patient comes, they can see the past record, whether the hypertension is improving or not. Similar for diabetes, anemia, vaccinations. So at click of a button, they can see the past records. And the community, based on their requirements, get health education messages or reminders for taking medicines or for adopting healthy lifestyles, as well as for appointments for follow-up visits, etc., in a local language. So that is the community outreach for education. And health care workers, they use from the clinic, that from where the patients are coming, can use this GIS map to see clustering of cases for epidemiological purposes. This is an example of TB, but they can see for fever, diarrhea, anything which is coming to the clinic. And then administrator as a medical officer, some indicators of work, how much work has been done over a period of time, week-wise, month-wise, year-wise, etc. So these automatically, these dashboard which is needed monthly, they can be generated for the monitoring of the services by the administrator. So this is how this was implemented for a couple of years. And what we found through evaluation compared to other health centers which did not have any digital technologies, that it improved access, there was better coordination and comprehensive care, there was better health promotion and care reminders, and it ultimately led to better health service utilization. But to say that whether this digital health improved health outcomes like effect on morbidity, reduction of illness rate, or reduction of the mortality, that is a question mark. And then another question mark is that this also cost money, implementation of this type of digital technologies, whether that is justified or not. And in a complex health system, it is very difficult to evaluate, the effectiveness of only one component when it is changed. So we see that in any implementation research, you see this model given by Professor May, we keep in mind that this, because digital health is also a complex health intervention, it affects, the capabilities. It's a complex intervention. Possibilities presented by a complex intervention. It depends on the capacity, the structural social resources available in the health center, then cognitive capacities of the health workers who use it, and then how it is contributing to the improvement. So many factors have to be kept in mind while introducing digital technologies in the health system. Another thing is this digital technologies, they appear to be very simple, but it is it's a complex web. Many things have to improve or need to be taken into consideration for success of it. So like systems should be interoperable, then they need to be low cost, bandwidth should be there. So many things need to be in place before we can use technology successfully in the healthcare setting. But despite all the difficulties, there are many opportunities which we have now for using digital technologies in healthcare. So one can design algorithms and use it because these need very high computer speeds. And on the other hand, healthcare costs are rising because the use of advanced technology in healthcare cost is rising. So many healthcare planners, they recognize that maybe the digital technology use might be, ultimately a cost saving, and therefore they may like to invest in it. There are huge unmet needs in the health sector, especially in the remote rural areas. And maybe some technologies like telehealth, telemedicine, etc., might address some of these needs. Therefore, technology developers are paying more attention to use of technology in the healthcare setting. Then even this Ayushman Bharat Digital Mission is now seeing an opportunity that how we can leverage this technology to having reports and information from the private sector, which had been a problem. So how to connect the systems together from private and public. Since now Ayushman Bharat National Health Authority, they have this PMJ, and even private sector is also providing care, and government is paying for that. And moreover, another opportunity is that people and providers, they are becoming more familiar with the digital phones and smartphones and computers, because they use it for digital media, for communication like WhatsApp, emails, etc. It's no more a exotic kind of thing. Even in the villages, people have started using these technologies. So these are some of the opportunities which one can utilize for introducing digital health in our country. But there are, in addition to the challenges now and opportunities, there are some of the things which I would like to suggest in the way forward. is, the governance related issues, some of the issues related to approach and design and implementation, and few issues for evaluation and for developing competencies in this field. So for governance, we have several, policies and regulations. Some of it is already approved by the government. For example, this open and free standard. So this is now a Government of India policy that we need to use open and free standards. The advantage is that we have the source code and everything, and these do not cost. Whereas the proprietary software, they are, one has to subscribe them. And most of the proprietary softwares, you have to give the subscription every year. Just like when you install Microsoft Word or Microsoft Office, you pay for it. Not only initially, but many of the softwares, they would ask for subscription, which is to be paid every year. And any change we want to do in that software, again, one has to approach that company. So this is the advantage of the open and free standard. These can be customized, and government has now policies on it. Another one is interoperability or data exchange. So every software, they have ownership on it, but the government has now a policy that all the software, they should be interoperable, which means they should be able to send their data from one software to another software. They are able to exchange the data. So these policies have been framed. Even telemedicine, telehealth policy has been framed during the COVID-19. Even e-pharmacy or e-prescription, etc., have been made. But we still do not have very solid regulation for data ownership and data use. So these are under discussions. Who owns data, who uses data, how to de-identify data, etc. So we need better regulation on it. And this liability for algorithms, because many of these smart software, they have built-in AI. You see, like if you use it for and record patient data into it, the software will say that this patient is a very high risk patient. This patient has a cardiovascular risk of dying, over the next 10 years, 20 years is this percentage. So this kind of, or if there are images, the images are read by AI and, diagnosis is given. So this kind of, if there are any errors in that, maybe the algorithm is not framed or not formulated properly in the context, then who is responsible? Is it the physician who is using it, or it is the software company who have prepared it? So we need some kind of regulation on that. And privacy, how to keep the data confidential, how to take consent before we use that data, and whether the data belongs to the hospital where a patient has gone, or it belongs to the patient. Now the policy is, generally agreed policy is that data belongs to the patient, but before we use that data, the consent management systems are required, which need some kind of a regulation. And the last of all, there are issues related to the ethics, and ethics particularly about equity. We still have a digital divide in the world, and in India also. It will take time to bridge it. And so in the process of, promoting digital health, one has to see that those who do not have access to this technology, they should not be left behind in our effort of, delivering UHC for everyone. So that also has to be kept in mind. For approach and design, what approach one should take? You see, as the provision of comprehensive healthcare in the community setting is to be done, and such a large country as India, such a diverse country as India, where health system strength is also, it varies from very poor to very good, and where we have, private sector and public sector, both types, and some NGOs and trust also provide services. So should we have a centralized system which operates from one place and everybody uses that system, or should there be, decentralized system, which means states and cities or hospitals and, NGOs and other entities, they have their own system, and then they send their data, whatever is required, to the state and central level. And those systems people might have more trust in their own system because the data will remain there at the local level. And then there may be more integration of those systems at the local level. So one has to see that they address the health needs at the primary level, secondary level, tertiary level, how to link all these. So it's rather than making a very, very complex one system at the country level, it is better to have a modular approach, decentralized modular approach. One can have a software for primary care, another one for secondary care, tertiary care, and then these systems can be interlinked with each other. They be made more interoperable. Because to give you an example, in the primary care, the number of health conditions which a doctor will see is very limited. Number of images a doctor sees is very limited compared to a tertiary care. So if a system is designed for a tertiary care and it is implemented in a primary care, the system is too heavy, the computers will become slow, and it is unnecessary. Most of the fields will remain blank at that level. So approach and design needs to be thought about and discussed, deliberated. Now, once we design the system, the implementation also has many challenges. So whether we have the required infrastructure, and this infrastructure durable in nature, the computers and the software, they change very quickly. Once you supply some tablets or some computers for the health workers, for the health centers, within 3 years, 4 years, these are outdated, and the next set is to be provided. So it is not that once a computer or a printer or some hardware, some software is available, it will last forever. So one has to see that aspect. And then technical support. Not only you need this hardware, software, but you see there should be some support locally also to troubleshoot. Because even minor problems, you see, one cannot wait and call technicians or engineers from distant places. And another one is, in implementation, the challenge is competency of the users. You see, some of us who are in their 50s and 60s are not very comfortable with these newer technologies. Maybe those who are in their 20s, 30s, 40s are. And so developing these competencies among the users is important for implementation. And commitment from all the stakeholders, whether it's frontline workers, doctors, administrators, technology developers, need a commitment from all of them. Only then implementation becomes successful. And above all, whenever anything new like this technology, it costs money also. So one has to think whether to invest that kind of money in digital technology, particularly in a situation when most of our health centers, they do not have all kinds of medicines in reasonable quantity. And our health workforce is also, we have shortages of the health workforce, shortages of buildings and beds. So our so many shortages are there. We live in a situation where health budget do not increase year after year. It is very low, nearly 1.2% of the GDP. So in this situation, where to allocate budgets, whether to send budgets more for meeting these needs of human resources and supplies, or wait, justify the investment in digital health in view of these competing priorities, which I just mentioned. Assessment, therefore, are required that whether by implementing digital health, we achieve efficiency. Efficiency means whether we can do the same work in less money, or whether we can do the same work in less time, etc. And whether it improves safety, improves quality and safety. As I mentioned, whether use of this AI, etc. If there are errors, that kind of thing. And ultimately, whether we achieve better results on reduction in morbidity, if we educate people using technology, as our Pro Vice Chancellor was mentioning, Satyakamji, that people also need to see their behaviors, their lifestyles, if they get all type of information, and whether they use it, number of diseases become less. And then those who are sick, if they get early treatment, better follow-up. So whether with that mortality goes down. So ultimately, our economist might have to do some cost effectiveness studies, that how much we are investing in it, and for that investment, whether we get the impact. So that kind of thing has not yet been done formally for this kind of thing. Although nowadays there is some use of what you call health technology assessment. In India also we have a health technology assessment board, and they have started doing some work. But so far, this aspect of digital technologies has not been taken in that health technology assessment board. So evaluation is needed for these technologies. And last of all, since we are organizing this seminar in IGNOU, which is a premier university of India, has pioneered many distance learning programs, and IGNOU is the first one, I guess, to use this radio, TV, satellites, and many more technologies right from its birth to educate people who are already on job. So maybe with the help of IGNOU, one can design digital health curricula for health workforce of all kinds. Now, School of Health Sciences in IGNOU, many courses are there. For nursing course is there, and then there is a course for medical lab technology also, and likewise many courses are there. So these curricula which are designed, there should be a component of digital health. And then one can think of creating new workforce with this technology, like this health informatics. This is a new field, maybe a new course. People who have this type of skills, maybe know more about medical records, how to maintain these systems in the hospitals as well as in the community. And then, we had earlier this statistical assistants. Now with the huge amount of data which is becoming available, so maybe something on this, big data analytics, some courses on this type of thing. There are formal courses, but like IGNOU pioneers, these courses which people who were trained earlier but want to upgrade their skills, they can take advantages of these courses. And we also, as started a short course on public health informatics of 1 week duration. We conducted 2-3 such short courses in which we invited people from the health and from engineering, because engineering and health both have to come together to understand each other and help each other in implementing digital technologies in the health sector. And maybe to train large number of people on this, existing workforce on this, maybe IGNOU can think of organizing some online courses, the way we are doing this webinar. And if courses can be designed in that manner, then large number of people can be made aware about these technologies and they can acquire competencies, skills to do this. Because now health technologies these digital technologies are being utilized on scale in many state governments. And many frontline workers are using them. Pharmacists are using them for inventory management. Even administration is using them for personnel management. So even in the finances also, health financing, these electronic systems are being used. So in several places. So we need to develop competency of this huge workforce for digital health. So these are some of the way forward for digital health. I think in future, there will be more use of digital health in our country. So with these words, I would like to thank you for listening to me very patiently. And I hope that you might have some queries or some questions. If you have, then I think we have 5 minutes. And if you have any questions or query, I would take them up. And before I end, I once again thank IGNOU for giving me this opportunity of talking to you, interacting with you. And I was very much enlightened by the talk by Satyakamji, very philosophical talk which he had. I think we need that kind of perspective also. And Dr. Suneela Garg, she painted a very gloomy picture of health and, this climate thing. So hopefully in coming days and times, we will pay more attention to this because all we know is that our health is completely dependent on the health of the planet. If planet is there, then we are there. And let us see how we use technologies to protect health of planet as well as health of humans and all living beings actually. So with these words, thank you very much.
Thank you, Dr. Rajesh, for your inspiring and insightful talk on digital technology in healthcare. The focus on the opportunities, perspective and possibilities, and also the drawbacks which you highlighted really enlightened, I think must have enlightened all the viewers. And the model which you have developed and implemented in the urban primary health center regarding the preventive, promotive, and other comprehensive primary health care is also very eye-opening that it has worked and it has been developed very well. I think in future, the preventive and promotive aspects can be taken very well digitally, and also the follow-up, referral, and all those things can be also taken up digitally. And this all of us have seen during the COVID, we all got the consultations digitally from very senior experts. Maybe it COVID, maybe it other problems of health, diabetes, hypertension, or any other thing. So this is how we utilize and how we take note of what we are doing and what we are learning. I think if anybody has any questions for Dr. Suneela Garg and Dr. Rajesh, I would request them to put their questions. If they have any clarifications to be made, or if they want, if anybody wants to ask any question, kindly put your question.
I think there is one question which talks about data security and consent to use patient data is an issue. That's in comment, so that is important. Another one has been pointed out that data security is another issue that may be used by MNC of a pharmacy related industry. So these are the concerns which are expressed. So if you like.
I mentioned in my talk, these are the 3 areas which still remain. Actually, Government of India has drafted 2 bills to address these issues.
Yes.
And now, after deliberation, what they have decided is that let us have 1 bill, So they are trying to have 1 bill to address these 2 issues, important issues. And we hope that very soon these should be passed in the parliament. They are getting delayed from my perspective, because we have launched, Ayushman Bharat Digital Mission, but without these regulatory, or backing of the law, it will be very difficult to protect data and privacy, etc. Although they are saying that now we will build into system, the users will give the consent, that consent management system they will have. But it is better to have a law backed by parliament. I completely agree with the concerns. Thank you.
Any other question?
Sir, can I ask Madam one thing?
Yes.
The concern is, sir, it was a very enlightening session by both of you. And it's nice to listen to Dr. Suneela after a long time. And one thing is getting a data from private sector. It is a big concern. Whatever data is available in India is mostly from the tertiary level healthcare system, and now maybe some data from the primary sector from the time the mission has been launched. But it is a big concern from the private sector because the clear picture is not available still. And out-of-pocket expenditure is very high in India. If we see still, it is, although the Ayushman Bharat is being implemented. So will the digital health will have those concerns taken care by these digital health system, that these concerns will be taken care of?
Well, if the question is directed to me, maybe Dr. Suneela can also contribute. I think the Ayushman Bharat digital mission has very specifically stated that it will be for both public sector and private sector. And the idea is that private sector has its own data. They should also have their own data. And what is being discussed is that, one approach is that every medical record of 1.3 billion people is stored at one place, okay, which is going to be very difficult, you see. So what I suggested in this talk is that let everybody have their own data, private hospital, public hospital, people, they have, but the aggregate data for decision making, we should share only that rather than sharing everything, because there are issues of data breach also. If you have everything in one box and somebody breaks its lock, so all the treasure is gone. If the same thing is stored at 100 places, so it becomes easier to safeguard also. So as far as that is concerned, now digital health, whether it will reduce cost of care, this is your question, OOP, etc. Because you will need to invest in digital health also. So I'm not sure about that, but one thing is there, that this National Health Authority, now they have this social insurance, or what we call government health insurance, for 40% of the population. And some of the state governments, at least 50% of the state governments, they have gone in for the universal health coverage also, which means not only this 40%, through their state resources, they are covering rest of the population. Recently, Rajasthan has done it. Uttarakhand has done it. Many, I think half of the states, they have gone beyond this, Pradhan Mantri Jan Arogya Yojana. And now these are in the initial stages. Okay. So still these benefits are not yet realized by the people. You see. So this is, there are many factors for it. That lack of awareness is there, lack of facilities are there, and so it will take time gradually for people to realize it. There is no formal evaluation of NHA also, although it is functioning for the last 3 years. So the systems are still not perfect, I would say. And this OOP, as you mentioned, even if all government facilities are providing, in theory, this is becoming longish, because the question you asked is very, maybe we can have a talk on this someday, because OOP is not only in the government sector, but even the private sector. We don't have health center in every village for that matter, you see. So in every village there is an RMP. So the RMP charge.
But sir,
I will
stop
try
here.
to say something.
yeah, sir, I will like to add one more thing, that basically, the problem comes where private sector is there. They're also participating in a lot of health initiatives. And one of the initiatives in which we have now made an indent is National Tuberculosis Control Program, where, the data is being digitalized to some extent. But one of the things where, the major challenge is also, like we have got COVID platform for vaccination of COVID-19, but then private practitioners are utilizing even, they are not using even platform. They are the major consumers of vaccines also. So somewhere I think to begin with, we can start with the national health programs and then with the morbidities and all that, because private sector still remains a challenge where, we are yet to tap the data. So that is where we have to make our approach in that direction. And you rightly said that our objective is to reach the last mile. Sorry, Dr. HP, I just came in between. So you were telling something.
Dr. Varadarajan?
Yes, madam. I am Varadarajan. I am Regional Director from IGNOU Regional Center, Bijapur. I have given a lot of comments for madam as well as for it was a wonderful talk. The issue is that in the digital health informatics, the main issue is the data confidentiality, and it should not be leaked at all, because it is a very individual, very sensitive data. Suppose a patient is suffering from HIV, or a adolescent girl is going for some induced abortions. Such kind of very sensitive data, when we put in the digitalized mode, it should not, leaked or anywhere. And second thing, what I suggested, a big data analytics, sometimes it will be hijacked by some multinational pharmaceutical companies for their company benefit. This is also one of the major threat when we are maintaining a chunk of big data in digital mode. As far as madam is concerned, madam said very rightly, affordable water. Madam, I want to tell you, milk is very cheaper, but water is very costly. I have given comments. Now, the commercialization of the soil and commercialization of the air and commercialization of the water, these are the big issue. Our health experts think very carefully how we can put and suggest to the government not to commercialize this environment, the whole planet, so that it is owned to all. This is what I want to share.
And I want to share one more thing here, sir. When the public water is, drinkable water, because every one of us goes for a bottle of water from a commercial perspective. So I feel that it is high time that we have, trusted source of public water, so that we do not go outside. In US, when you go, we all are drinking the common water. We don't go for water bottles and all that. So that is high time where each one of us has to emphasize whatever supply we get has got to be a drinkable water. That is there, and we need not go for commercialization.
Yes.
Now I'm
Yes.
reading your comments,
you.
sir, in the chat box. Very useful.
Thank you so much for asking the questions and also replying appropriately to all the questions which have been raised here. I think in future we may have more sessions and for more time also. Now I would request Dr. Rita Devi to propose vote of thanks.
A very good afternoon, and thank you so much, ma'am, for giving me this opportunity. On behalf of School of Health Sciences and on my personal behalf, I take this opportunity to present vote of thanks on the occasion of World Health Day. As at the outset, I thank Honorable Chancellor, Professor Nageshwar Rao, Indira Gandhi National Open University, for his active support, encouragement, and giving all the motivation for all the programs of health sciences and in general, and to celebrate the World Health Day today in particular. I thank you, sir. Professor Satyakam, sir, our esteemed Pro-Vice Chancellor, IGNOU, for being presided over this very important day and taking out time from his busy schedule and delivering a presidential address where he mentioned that हमारी पृथ्वी एक नायाब ग्रह है जिसपे जीवन समर्थ है और सामंजस्य के साथ अगर हम सब चले तो बहुत कुछ हो सकता है और अगर हम उल्लंघन करेंगे तो वो हमें सभी को परेशान करेगा. Sir, thank you so much. You have given insight to all of us with your simple words, and your active support and encouragement give us inspiration to organize such events in the past as well as on every health related issues which we are doing with your support. I thank you, our Pro-Vice Chancellor, Madam Sumitra Kukreti also. She had been participating in this. This shows the importance of this day today. I thank you, ma'am. I sincerely owe my gratitude to and special thanks to our experts, Dr. Rajesh Kumar, and express my sincere thanks to Dr. Suneela Garg, ma'am. Both of our experts have given their detailed views about the digital revolution in healthcare for the sustainable development as well as our planet and our health. Thank you so much, ma'am, for apprising all of us, and to Dr. Rajesh sir also. Professor Pitikol, Director, School of Health Sciences, has been the source of inspiration for initiating every activity of the school, as well as this activity which was just planned few days before, and the initiative taken by Madam to celebrate on a very short scale is inspiring, and she has worked untiringly to make this program a dream come true, and I am thankful to you, Madam. Then I am very much thankful to all the faculty members of School of Health Sciences for their consistent support and guidance, as well as and when needed. I thank you all, as well as I thank all the staff members of School of Health Sciences and Mr. Rohit, who has been coordinating various activities to make this webinar a success. I pay thanks to all the directors of schools, all the regional directors across the country, head of all divisions and head of all units, and special thanks to Director, Center for Online Education, for timely disseminating information across all regional centers and regarding this event, and the faculty members, academics and other academics, and IGNOU employees who have joined this important webinar today. I thank all of you, and thank you to their organizations making them available for us today. Last but not the least, my thanks are due to Ms. Monica Shah. She is our project assistant, and Mr. Mithun Senapati from COE, who had been working working behind the scene tirelessly. Once again, I thank one and all for attending this party and participating in this webinar. and making it successful. So stay safe and healthy. Thank you all very much. Thank you, ma'am. once
Thank you
more.
so much. Thank you very much. Professor Satyakam is there. He would like to say something. Sir, should we close the meeting? I think I once again thank you all, especially the experts who have spent their